I think we have Dr. Narang with us. Welcome, sir. Thank you. Thank you for joining us. Yes, good evening, sir. And thanks a lot for contributing always to the alumni group. Really, really thankful. A lot of people
Whatever
are...
I know, whatever experience I have, I always I'm very vocal about it. I tell very frankly.
Yeah, great, sir. Thanks. And you've done a lot of high hands, I believe.
Yes, must be about, I think, more than 3,000.
Great, sir. We learned a lot from you today.
Okay, good evening, Padmaja Sudhakar from University of Kentucky, and thanks to Dr. Shika Basi for inviting me. I'm a former trainee of Shankar Nethralaya, and I'm a practicing neuro-ophthalmologist in University of Kentucky. So today we'll be talking about an interesting case, and this case was very challenging even for me, but it's very interesting, so I thought I should share it with all of you. And also want to take the opportunity to thank the co-authors of this presentation. I have nothing to disclose. So we had a 29-year-old woman. She was Caucasian, and she presented to the neuro-ophthalmology clinic after she was found to have a suprasellar lesion. So the story is that she was on birth control, and then she stopped it with a desire to have a second child. She already has one living child. But after stopping, she did not resume menstrual cycles for about 5 months. But then she went on 2 rounds of progesterone-only pills, and then cycles resumed. So at this time, OB/GYN performed a workup. They found that she had elevated prolactin, and they placed her on cabergoline. So whenever someone has elevated prolactin, you think about pituitary tumors. And so they did an MRI. First, they did a regular MRI brain. They found a suprasellar lesion. And then they did this dedicated MRI focused on the pituitary gland. And you can see 2 sections. On the left, it's a T1 weighted image. And you can see a suprasellar lesion here, which was T1 hyperintense. And then this is a T1 with contrast sagittal image. You can see this T1 hyperintense image. And then there is like a rim of enhancement. Then these are coronal views. This is T1 coronal with contrast. Again, you see this suprasellar lesion with a rim of enhancement. And this is a T2 weighted coronal image. So the suprasellar lesion is actually impinging on the optic chiasm. It's like kind of stretching out the optic chiasm. So based on this evaluation, everyone suspected that this is a pituitary adenoma. And as you can see, since the pituitary adenoma was putting pressure on the optic chiasm, of course, we need a neuro-ophthalmology exam. So that's how she came to our clinic. Before she came to us, she also went through endocrinology, did not have any endocrine symptoms. So the standard things you ask are, you have hirsutism? Do you have like a purple striae? Do you have anything like galactoria? Do you have polyuria, polydipsia? None of this. She didn't have any of these symptoms. And then they did extensive pituitary hormones because she has a pituitary tumor and all the pituitary hormones were negative. The prolactin alone was low. And the reason for that was she had been placed on the cabergoline, which is to suppress the prolactin level. But the endocrinologist determined, looking at all the MRI, that she did not really have a prolactinoma. The prolactin levels were elevated because of something called a stalk effect. So from the pituitary stalk, sometimes you have leakage of hormones, and that can falsely elevate your prolactin levels. So this was thought to be a stalk effect. So they asked her to stop cabergoline. So overall determination was that this is a non-functional pituitary adenoma, which needs surgical resection. But all these cases, before going through surgery, they get a neuro-opthal exam. So when she came to our clinic, she told me that she was having pressure-like headache for about a year. And she was attributing it to her sinuses, which like a lot of patients say that, but she had never seen ENT. So, it was funny because she said, I have sinus headaches and never seen ENT. And then vision-wise, she would say that like the left eye would have some peripheral vision loss during headaches, or sometimes she'll see some splotches of light, or, she'll have a headache and then she'll have blurred vision for a few days. So all this was very vague. And then, when you hear these kind of symptoms, you would think more, is this a migraine? And she's having some visual symptoms with her migraine. So things were not very clear cut. But she told me she's never had migraines and the headache is only going on for about a year. She also mentioned that she has 100-pound weight gain from her first pregnancy 7 years ago, but she didn't have any pulsatile tinnitus or dizziness or, pressure headaches. None of it would fit with like a pseudotumor cerebri symptom. The past medical history was only significant for asthma and depression. There was some diabetes and hypertension in the family. She was a former smoker, but at this time she was not smoking, drinking, or doing any substances. So I did the neuro-ophthalmology exam and stone cold normal. Visual acuity was 20/20 in each eye. Color vision was normal. Pupils did not show any afferent pupillary defect. Intraocular pressures were normal. Anterior segment was normal. And then on the fundus exam, the optic discs look very healthy. There were no other retinal changes. These are the visual fields. So we do a 24-2 CEDAR-FAST. As I showed you, this tumor was compressing the optic chiasm. So I was hoping to see some changes. Luckily, the visual fields were normal. And then we always do an OCT in these cases. So the retinal nerve fiber layer analysis was pretty robust. Of course, you can see some areas of dropout, but this wasn't of significance. The ganglion cell analysis was also intact. So that pituitary tumor that she had, in addition to putting compression on the chiasm, was also displacing and I can show you the picture again. It was also displacing the cavernous ICA and the supraclinoid ICA. So these are just adjacent to the tumor. So neurosurgery was going to operate on her, but made sure that they got a CTA of the head. They did not see any compromise on the cavernous ICA. So they decided to proceed with surgery. So standard for pituitary adenoma is that you do a transsphenoidal resection and remove the tumor. So the transsphenoidal is done through the nose. But here they go in and then there's a surprise. So instead of seeing one solid tumor that they were going to remove, they had a gush of pus on the table. So this ended up not being a pituitary adenoma, but a pituitary abscess. And our surgeon, he's got 15 years experience, and this is the third case that he had seen in life. So then they took this material for histopathologic exam. So it had necrotic debris, there were degenerating cells, and the culture was positive for two organisms, methicillin-resistant staph epidermidis and Cutibacterium acnes. So immediately infectious disease was consulted. They started her on broad spectrum vancomycin. But unfortunately, I think she didn't have a good time. A week on vancomycin, she develops something called DRESS syndrome. This is a very severe drug reaction. We usually see it with the anti-epileptic drugs. Unfortunately, she had this. She had a rash, redness, skin peeling, nausea, vomiting. So they had to stop the antibiotics. And then they put her on tapering doses of prednisone. She recovered well. And then this is the immediate post-op. So this is like 3 days after surgery. You can immediately see the collapse. There is no more of that pituitary abscess. You can see the chiasm here. So it was coming down. And this is MRI a few weeks later where there's no pituitary abscess anymore. There's no recurrence. You can see the pituitary stalk. It's a little deviated, but things were looking good. So she came for the follow-up to the neuro-ophthalmology clinic and she said she had resolution of headache. no more visual complaints. She had started back on normal menstrual cycles. And then they made sure all pituitary cases after surgery also get a follow-up evaluation of the pituitary hormones. So none of the hormones were abnormal. So she didn't need any replacement. And then they did follow-up nasal endoscopy twice. It was all clear. And then the follow-up neuroophthalmology exam, again, stole cold normal, maintaining good vision, no visual field loss. Few weeks later, she came back again saying, oh, I'm having worsening headache. They repeated the MRI. And now just within the intracellular space, it did not go supracellular, just within the intracellular space, there was a recurrent abscess. She went another time to surgery. So they did a transsphenoidal drainage. Again, there was pus. So then they put her on 2 antibiotics, ceftazolin and metronidazole. So she got total 8 weeks of antibiotics. Then she's continued to have the follow-up MRIs. It's always contrast enhanced study. So there's a stable decrease. There's no recurrence of the pituitary abscess. But within that cellular space, she has a little cyst. And they just think it's a post-operative fluid collection and not a recurrence of the abscess. They continue to monitor her pituitary hormones. That's very stable. She's got very minimal headache. She continues to come to the neuro-ophthalmology clinic and her exams have been normal. No vision loss, no visual field loss. So I wanted to talk to you guys about this pituitary abscess. So this is a very rare clinical entity. So you have 3 types of abscess. It can be a primary abscess, which can just arise from normal pituitary tissue. It can be a secondary abscess, secondary to a lesion within the pituitary gland, like pituitary adenoma or a craniopharyngioma. Or it can be what we call an iatrogenic pituitary abscess, where someone had a pituitary tumor, had a pituitary surgery, and then the abscess develops many years later. So you wonder, right? Nobody hears about infection in the pituitary gland, but it is possible. So it's a gland which is very vulnerable to infection because of its immunologic and circulatory deficiency. The pathogenesis of the secondary pituitary abscess is not well described, but some of the theories are a hematogenous dissemination of infection from elsewhere, or there is an extension of infection from surrounding areas, like from the meninges, from the sphenoid sinus, from the cavernous sinus, etc. The sphenoid sinus is considered to be the closest site where you can have the extension of infection. And remember, when the pituitary gets infected, the pituitary is the hormonal control of the body. People can develop a hypopituitarism, and that will make people vulnerable to more infection and risk of infection. So when we looked at the pituitary abscess prevalence, it's apparently less than 1% of all pituitary lesions. And then I looked through, there are only some 250 case reports. It's been described as early as 1948 and 1914. And then the first case of pituitary abscess, which developed in a pituitary adenoma, was somewhere around 1952. But like not many cases, some 250 case reports and 40 cases of secondary pituitary abscess. And then we talked about these various sources of infection. So it could be if people are in obvious sepsis or in bacteremia, or there's been a pituitary surgery or a sphenoid sinus surgery, or there's sphenoid sinus infection, or there's a spread from one of the sinuses. Remember, the cavernous sinus is adjacent to the pituitary, and that can also be a source of infection. So when these abscess fluid is subjected to a microbiologic and histopathologic investigation, the positivity rate was only 30 to 50%. So the common organisms are the gram-positive cocci, like the staph and streptococcus, like seen in our case. But you can also have gram-negative organisms like Neisseria, E. coli, and Corynebacterium. Rarely it's a fungal or parasitic infection. Majority of the time, the cultures are sterile. And then some theory is there that this pituitary abscess may not be a bacterial infection. Probably the pituitary got infarcted and this is an inflammatory reaction in the pituitary. But they also said the endocrine abnormalities can be caused by simple inflammation of the gland. So it's got a higher female predominance. Age range is wide. They've had cases as young as 12 to as old as 76. And then in a secondary pituitary abscess, which is pituitary abscess in someone who's had another pituitary tumor, like a pituitary adenoma, they saw some male predominance. And then the duration between the onset of symptoms and diagnosis is about 8 months. So coming to the clinical manifestation, it has an indolent course. It's a subacute presentation and vague, non-specific symptoms without septic symptoms. Even our case, she had vague visual disturbance and some weird headache. And, if the amenorrhea after the stopping the birth control had not happened, she would not have even come to our attention. Some of them can have diabetes insipidus, some of them can have hypopituitarism, but overall, it's not standing out. These complaints are not standing out. It's just very, very vague. And then majority of cases don't have the infectious symptoms. They don't have fever, they don't have meningismus, they don't have leukocytosis. So making a correct preoperative diagnosis is relatively low because you have to depend on your MRI. Radiologically, it's still very challenging to differentiate a pituitary abscess and an adenoma. And the interesting thing is the CT and MRI findings of both are more or less the same. Some have described doing a single photon emission CT scan where there was a high uptake of the abscess, but you don't do the SPECT often. Whenever you have a suspicion, you go only for a brain MRI, and the brain MRI cannot really distinguish between a pituitary lesion, like a pituitary adenoma, and this abscess. However, one thing you could do is that, both the pituitary adenomas and the pituitary abscess, they will be iso-intense on T1 and hyper-intense on T2. But the abscess has a ring of enhancement. So they have suggested that you could use a diffusion weighted imaging. So I don't know how familiar you guys are. The diffusion weighted scans are usually used to diagnose stroke. So if you have someone with stroke on a DWI image, you will see restricted diffusion. Similarly, if they have a brain tumor like a glioblastoma or a lymphoma, you can see a restricted diffusion. Brain abscesses can also produce restricted diffusion. So they're saying that if you use the DWI sequence on the pituitary, then maybe you can pick up a pituitary abscess, maybe it will show restricted diffusion, and then you will know that, this is a pituitary abscess and not a pituitary adenoma. So treatment-wise, surgical drainage is the treatment of choice, and they said that the transsphenoidal approach is the best. But if it's a huge lesion, then you have to do an open craniotomy. And then the transsphenoidal endonasal approach is kind of better because there's a lower chance of dissemination of the infection into the subarachnoid space. And then some surgeons advocate putting a nasoseptal flap and a fat graft for the skull base reconstruction when the CSF leak was noted. Others say once you drain the abscess, leave the area open, because if again the abscess forms, it can drain. But as you all know, any surgery is not without risk. So, there's chances just from the abscess fluid disseminating in the brain space, you can get a meningitis. It's possible to damage the vessels. It's possible to have a CSF leak. But with modern day techniques, so it's now the transnasal endoscopic, transsphenoidal resections are very well controlled, and, so the chances of complication is much less. Now, the only important thing about this pituitary abscess is that you must focus on hormone evaluation. So these people need to keep getting pituitary hormones evaluated, because, if your pituitary is shut down and your hormones are out, then, it's very life threatening. So you have to keep checking the hormones and make sure that the hormones are replaced. And if there's diabetes insipidus, they may need the desmopressin. So besides the surgery, remember this is an infection. So you have to identify the bug and give the specific antibiotics at least 4 to 6 weeks. But I also said that 70 to 80% of the time, they're not going to have any septic symptoms. And in good majority of cases, the bug is not even identified. So in such cases, you have to do empiric antibiotic therapy. And again, they repeatedly say, keep monitoring the hormone levels and replace the hormones. Coming to prognosis, now, it is a life-threatening condition, but lucky, majority of cases have had a very chronic course. 75% of patients had good outcome. They did not lose vision and they kind of maintained their pituitary hormones, but there has been mortality in about 26%. Now, recurrence of these pituitary abscess is rare, but in our case, we had a recurrence where they had to go in again and drain. And then again, you have to focus on the post-op hypopituitarism that needs regular follow-up. So overall, this pituitary abscess is quite a rare condition. But if you see a patient who's referred to your ophthalmology clinic with a pituitary mass, and there is evidence of hypopituitarism, keep this condition in mind. Preoperative diagnosis is going to be quite challenging because the symptoms of pituitary dysfunction are not specific, and symptoms like headache and visual disturbances are vague. And then imaging is very, very non-specific. But if you have a good radiologist, you can ask them to see if they can use a DWI sequence on the pituitary and find out if there is an abscess sitting there. Most of the time, the preoperative diagnosis is infrequent. Majority of cases are diagnosed intraoperatively, and surgery is the treatment for any pituitary lesion. So after surgery, these cases also need prolonged antibiotics. And when you follow up these cases, you have to continue doing the ophthalmology exams, which should include visual fields, which should include OCT. You should also ask for periodic brain MRI dedicated to the pituitary, make sure that the abscess has not come back, and make sure that the endocrinology is also following these patients, making sure that the hormone levels are appropriate.
Great talk, Padmaja.
Thank you too. I can take some questions.
I'll just pass on a comment.
Yes.
Yeah. So very interesting, Dr. Padmaja. It's quite pituitary abscess, as you know, is very rare. My one concern was a pathological diagnosis made during the first surgery? Could the surgeon establish some scrapings of the wall and send it for a histopathology?
Yeah. As soon as they saw the pus, they knew it was an abscess, and then they found the two organisms. They took that pus fluid. That's what was sent for the testing.
Oh, pathology? Have they sent the wall? Could they take some wall? Okay.
Yeah. So the whole thing collapsed, and
Okay. It's very important. It's very important to do histopathology also of the wall, because as you know, sometimes we had a case similar. It was a secondary abscess, pituitary gland, adenoma operated, and then patient came back with some enhancing lesion in the sella. Went to the same surgeon, he did a drainage, and then he was started on antibiotics. And after 1 month of antibiotics, repeat MRI showed further increase in the size. So then that patient came to us. So this time this was more eccentric, so we decided we'll go transcranial, and we excised it, and the pathology was mucin secreting adenocarcinoma. So the whole pathology itself changed. So and then we sent the excised it, and then sent the patient for radiation. The other possibility, like sometimes an infected rat case cleft cyst or an infected apoplexy or craniopharyngoma sometimes also can. So it's very important that they take a wall sampling and just getting a biopsy, send it for proper histopathological examination. It's very, very important.
That's what they saw, like just the histopathology of the, like what you're saying, the lining and the wall that's the one which had the necrotic debris with degenerating cells. So there wasn't an alternate diagnosis. She's doing quite well. So hopefully they've solved the problem. But like, I think it was a shock when they went in because, he's very, very efficient surgeon that he like was trying to bring out the whole thing. And then like there was just this gush of pus, which was just shocking.
Yeah.
Yes.
Padmaja, it was a really fantastic talk. And you
Thank
covered
you.
every aspect, and it's really a beautiful case what you presented. And we have to keep in mind, though it's very rare entity, I just wanted to ask you, is there any preoperative radiological investigation which can differentiate? For example, you were talking about the rim enhancement in an MRI, which you can probably have an index of suspicion that this could be a pituitary abscess and this could be a pituitary tumor.
We went back and talked to the radiologist because the radiologist should have given us some, but in hindsight, they said that like maybe when we see, we should apply the DWI sequence, the diffusion weighted sequence, which like they focus when they see a brain tumor or when they see a stroke. They won't apply the DWI to the pituitary because it's, and then when you're seeing that rim, that's what they said, oh, maybe we should have used the DWI sequence. And I'm like, you guys, so they said that like, it looked very much like a pituitary adenoma to them. Now in hindsight, now knowing that this was an abscess, maybe, they should, they said in future, they'll try to apply the DWI.
Yeah. It's very difficult to differentiate preoperatively. I think it's very, very characteristic. So one should actually very high index of suspicion. Considering the rarity of the abscess so much, of course, the commonest thing. I just had one comment. Only thing is the prolactin was done, which was 54, and starting on cabergoline without. I think that is something which has to be taken because cabergoline, pituitary prolactin, just 54 is not a suggestive of prolactin. At least we should have more than 200 to suggest that.
Correct. That's what. So this was OB. Obstetrician started the cabergoline. Endocrine came on board and said, no, this is just a stock effect. So don't do it. And they stopped it, So but at least I was happy because if like her periods had not stopped and we don't even know why she had the amenorrhea. It was just like probably she was recovering from the birth control, but it kicked off this whole process. Otherwise, nobody would have known. And she was sitting with headache for 1 year and like, thinking it's like a sinus headache and didn't go meet anyone till the cycle stopped. So it was like a very good, just lucky, I would say.
Very nice, very nice.
Padmaja, we have Dr. Suresh Babu, sir, you remember?
Yeah, very well. How are you?
We have him with us here at a very short notice. Sir, your comments?
No, Dr. Padmaja, we congratulate you for presenting this case. I just wanted to add 2 or 3 things. Clinically, we have seen patients retrospectively before surgery. Most often, we don't suspect an abscess. And as I said, it is a surprise at surgery. And retrospectively, if you see, the visual symptoms are out of proportion to the magnitude of chiasmal compression. In tumors, especially cystic ones, there will be a large MRI wise, there will be a very significant chiasmal compression. That patient may not have clinical features of any field defect or something. Whereas here, the patient will have the features of some visual disturbances will be there, if not a typical bitemporal hemianopia. That's one thing we have noted in some of the cases. And then in some of the patients, Rathke's cleft cyst, even if it is not infected, it looks like an abscess at surgery. So unless we take in the wall, we may not know. Even then, sometimes the wall loses his typical histological features and the epithelium will be lost and we may not be able to make a definite diagnosis. The reason why I say is See, the chances of a positive culture is rare in pituitary abscess. You said only about 20% or 30% it is positive. Yeah, that puts us a question. I mean, some of the cases are misdiagnosed, wrongly diagnosed. Rathke's clefts itself can happen. That's one thing I wanted to, that we have seen in our own patients. In the sense that the patient had an abscess, we operated, we thought it's an abscess. But then when the patient came for review, the patient brought the MRI that was done many years ago, which showed there's a Rathke's cleft. So that's as Dr. Rupesh said, no, we have to make a wall biopsy, and that will clarify in some of the cases, not necessarily all. And then coming to the radiological differentiation of an abscess, in brain abscess, sometimes we do MRS. So if MRS shows, spectroscopy shows amino acids presence, then maybe we can suspect an abscess, the pituitary, but nobody does. As I said, no, we know there is a tumor or some compression and we operate. So it becomes very easy to decide. So it comes as a surgical surprise. That's the other thing I wanted to tell. I will say I should congratulate you for presenting this. Thank you, Dr. Padmaja.
So I remember this case. I saw her like 2 days before Christmas, exactly around this time. And then she was like, can I wait? I mean, like you're saying the eye exam is good. Can I wait? And all. And the surgeon was like, no, like you just tell us what the neuro-ophthalmology exam is. And I was like, it's normal. The OCT and fields are normal. You just take her right now, because you see that, right? The chiasm was nicely stretched. And I was like, no, you need to go. And so this happened just the week after Christmas. And it was just a shock to her. She's had like a poor, bad 1 year, with all kinds of things.
So we have seen patients with the tuberculous abscess also.
Oh, yeah.
Abscess of the pituitary gland, we have operated earlier, and they make, they make a good outcome.
Yeah, good. I mean, we don't see the tuberculous here. And this lady was just minding, she's a healthy lady with nothing, she's like, there's no pointer for why she would have developed an abscess. And, she was just minding her business, and she just wanted to have a second child. That's the whole thing which started the process.
I just want to ask one question to Suresh Babu, sir. Is there any difference in your approach between a pituitary tumor and a pituitary abscess? Same?
No, there is no difference. The only thing is we would like to avoid arachnoidal breach and CSF leak, because then there is a risk of a spread of the infection to the meninges. So maybe we will see that we drain it, and we like to avoid CSF leak.
Okay.
At the same time, as Dr. Padmaja said, if it is an abscess, then I will avoid putting a nasoseptal flap and avoid CSF leak and leave it open. So it is like something like a marsupialization.
Yes.
And even if there is some collection in the post-operative period, it will drain into the sinus. It will come out and not form a big abscess. So definitely the approach is more conservative if it is an abscess.
Okay.
So this lady, I saw her pre-COVID, like 2019. And then after the surgery, I think you guys would have also faced, like, you can't do a COVID test on these people after transsphenoidals, because her thing was open.
Not necessary.
No,
Not necessary. Not necessary. We can do. Because sphenoid osteo, by the time already 1 year, sphenoid osteo would have reformed. Mucosa would have reformed over it.
Well, she was kind of fresh post-op when COVID started.
Okay.
So, like, I think they were just swabbing the mouth, or like the oropharynx, and like it wasn't very clear, right? Because COVID in 2020, many of us did not know what to do, and everybody was following their own guidelines. So she was kind of fresh post-op around that time. And so, and then there was the theory about, like, at that time, all the hospital admissions were getting a COVID swab. And so in her case, I think they had to go in the mouth and not use the nose.
There was a question by Dr. Kumudini, I think.
Yes.
Yes.
I'm not able to follow the chat. Can you tell me what the question?
Okay, can you hear me now?
Yeah, yes, Kumudini. Hi.
Okay, that's a very nice presentation. Recently, I had a female. She presented with the pituitary infarct, pituitary apoplexy, and the lesion appeared as a ring enhancing. So, like DWI would have helped, I think so, in making a confirmed diagnosis. It's abscess or it's a pituitary. Yeah, she had a sudden onset of all the symptoms. So that was the one point in favor that pituitary apoplexy. But like DWI would have helped in making the diagnosis that it's the apoplexy.
Yeah, apoplexy can be done because T1 will be hyper. If it is a fresh blood, if you see T1, it will be hyper intense. Wherein abscess, it won't be hyper, it will be hypostial. So that is very.
It was a ring enhancing. The whole thing that was a salar mass, which was ring enhancing, extending suprasalary.
It still can enhance, but fresh blood will be more hyper on T1, which you won't see at all.
Chronic apoplexy, probably.
Okay.
Chronic apoplexy, yeah. Chronic, that will be very difficult to differentiate.
Could be an infarct also. If the infarct was the cause of the apoplexy, then.
But the infarct is also the source of these pituitary abscesses. So that's actually probably the radiologist should actually come in and tell us where, because you are going to see the MRI with the patient, like you don't know the sequences. So the radiologist probably should start using DWI more often, especially like Dr. Kumudini's case or my case.
Yeah, that patient presented recently. That's why I'm asking you. That would have helped. We made a diagnosis of pituitary apoplexy with the keeping in mind that the onset was sudden.
But did your patient also have pituitary apoplexy symptoms? Like, did they have a cranial?
No, she had a headache. She had a headache. Yeah, only headache. No other symptom. Like now, it's not necessarily that you get the neck rigidity or loss of consciousness. I don't think that they should be always present in all the cases. Just headache and sudden onset of neuro-ophthalmological symptoms bilaterally, one may think of that diagnosis.
Yeah, but my patient did not even have sudden headache. She's like chronic 1 year headache.
Okay.
So she's like a young female going around and thinking it's, like everybody, I think both in India and here, they think their headaches are sinus headaches. And I'm like, why you? So if
my
it's like
my patient had this, sorry, go ahead.
No, your patient had a sudden headache?
Sudden headache, and that was so severe that she had never had in her life. So I thought that must be definitely apoplexy. Now she will undergo surgery, then we will come to know what it is.
And did they do because pituitary apoplexy is just like so life-threatening. So was she getting like hydrocortisone?
She's admitted, she's on steroid and undergoing her endocrinological workup before they take her up for surgery.
Yeah. So my case was like not even so dramatic. It's just very casual, the whole thing, 1 year of headache. And then someone is treating with Kebergolin. And then like I was the one who pushed and said like, look, your pituitary is like really taking up the chiasm. You better have the surgery. Otherwise, she was just holiday season. Like this one whole month is holiday in the US. Very casual, And I felt bad also because it's like really suffered for that 1 year. Now she's stable. And then the recurrence is also not so common. Unfortunately, she had recurrence, so she had to go second time for drainage.
Okay. Thank you.
Thank you very much.
So it's iatrogenic is just iatrogenic. It's just a term. It doesn't mean that the surgery went wrong. And so they just feel that they just created a nidus and then the infection got spread there. It's nothing wrong. And they describe the cases which I described. They said like someone had it many years after their surgery. So it's not, I don't think we should warn any of our pituitary patients like, oh, at some point in life, you can have an infection. Because most of the pituitary cases anyway, the neurosurgeons regularly monitor with imaging, and then we're going to see them in ophthalmology and monitor the vision. I don't think we should get them scared of any. And majority don't. She did not even have a fever or white count. Even this is like in the acute setting. Right after I saw her, they admitted nothing. That's the challenge with these cases. I wish there was something else which warns us, because it's.
This is very well encapsulated, very unlikely to cause any systemic response. And coming to the question post-op, it is more common to have some sphenoidal mucocele or pyocele rather than having an pituitary abscess as such. It is so rare that one should, if it comes, just we need to see that.
I know. I don't think, do you guys warn them saying, hey, in future you can have an abscess? They'll just get scared and run away, I think, if you say all that. I mean, most of the times the pituitary cases, they have such a good outcome. Rarely you see a recurrence of pituitary adenoma. You keep seeing these patients, you and the neurosurgeon. So they're like, if it's a good academic team, and which like Shankar Nethralaya and many centers have, people who understand the disease will follow them. So I don't think we need to warn, but things do happen, so. No.
Fungal abscess of the pituitary alone, we don't see. Of course, we see skull-based fungal granulomas. We operate on them. Even at the time of COVID also, we saw patients with mucor. And but we have not had separate fungal abscess of the pituitary alone. Isolated, I don't think I have not seen.
It is easy for the fungus to go into the cavernous sinus rather than into the pituitary gland. So if the cavernous sinus fungal infections are more common than what you see in the pituitary as such. Pituitary has such a good blood supply. It's a very good hypophyseal portal system that the immunity is also very good. It's not like, so it's very rare to get. So it's a disease of exception rather than what you see. As Dr. Padmaja pointed out clearly, even if you see a similar case in the future, we will not again diagnose it as an abscess. We will rather again diagnose it as only as a pituitary adenoma.
Correct.
And then after this case, like when I scan MRI and there's like any, sometimes they write weird things. Like I've started talking with neuroradiology and say like, be more specific. They'll say, right, some inflammation is seen in the sphenoid sinus. Like, what are we supposed to do with these cases? Should they get a better evaluation? Because it's scary. Like, and then the patient will tell us, why didn't you tell us this? And I'm like, your pituitary looked good, your chiasm looked good. They commented on some vague mucosal inflammation in the sphenoid sinus. I started paying more attention and saying discuss with at least like curbside ENT colleagues, like, should we act on this or what should we do?
Unless there's a fluid collection. Because most of these cases, because there will be some nociceptal flap kept, so there will be some reconstruction. Invariably, there will be some amount of enhancement in the sphenoid in the floor of the cella. So we need not take it.
Not in post-op. Generally, so like say you are scanning an MRI, and then the neuroradiologist will write some vague thing like, oh, there's like mucosal inflammation in the sphenoid sinus. Like, should we act on those cases or like? Should we take it more seriously? No. Okay.
Not required. Fluid collection is the most important. If there's a fluid collection, yes. Otherwise, not required.
Can the sinuses be the sphenoidal sinus be the focus of sepsis for the pituitary abscess? That's what she is trying to ask, and we are. Yeah.
Sphenoid sinus, mucocele and pyocele are quite common. We do see quite commonly, but they don't get into because you have a very good barrier. There's a good cellular flow. There's a good dura. So to transgress that barrier is quite uncommon. So we are not seeing pituitary abscess secondary to sphenoid mucocele. In fact, after drainage of sphenoid mucocele or pyocele, the wall of the cella still will be very intact. So unless there's a retrograde venous embolism. But those are diseases of exception. It is not the norm routinely.
Good. I think Dr. Kumudini had a question.
Yeah, just out of curiosity, I want to ask you, once you drain this abscess, should we lavage it with the antibiotic like we do in other sites? Whenever we drain the abscess, we try to lavage it with the antibiotic solutions, or the sinuses also. Should we do it in these cases, or because it's an extradural abscess? So
there is no hard and fast rule we can do. We generally do gentamicin saline irrigation.
Okay.
So we can do that, and we don't have any culture during because of gram staining. So we can do gentamicin saline irrigation, and we can just leave it open. And
okay, thank you.
Thank you, Padmaja. Thank you, Dr. Rupesh, sir, Dr. Suresh Babu. Thank you, everybody, for taking your valuable time out. Really appreciate that.
Thank you.
So with that, we will move on to the second part of the Powwow, and that is a discussion. It's basically we are taking on from our discussion on the group, our SNI Alumni Academic Group. We've been discussing about the newer lenses. Those are the enhanced monofocal lenses. So to start the discussion, I would like to invite Dr. Ruth Lapte, Dr. Mohan Rajan, Dr. Sunil Narang, Dr. Bhaskar Srinivasan. Please, you can have your cameras on so that, I can talk to her. We also have, I saw a few other names. I think Dr. Vatsal Parekh is also there, sir. Please join us. Dr. Sri Priya is there. And we have Mr. Subrata Bhattacharya, and he's from Hoya. And please, let's everybody can join in. It's basically a very the name Powwow is it's a very informal kind of a thing. I don't want to give very formal touch to this discussion. Now the first question in this, we'll do the discussion with questions. Whatever we are writing in the chat, then everybody types. Instead of that, we'll the enhanced monofocals. What is our understanding, or what is our definition? Where is it right now standing? And if we can start with anyone, like enhanced monofocal in our, is it has it completely replaced the monofocals? Is it a monofocal, or it's an extended depth of focus, or it's replaced multifocals? Where is it exactly?
Can I start, Shika?
Sure, sir.
I think, thank you very much, Shika, for inviting me for this wonderful webinar. I think enhanced monofocal is, I call it the monofocal plus lens. It's almost completely replaced monofocal lenses in my practice. So I do only monofocal plus, or I go for EDOF lenses, or I go for trifocal lenses. These are the three options I give normally to the patients. Please don't get confused between monofocal plus and EDOF. There's a difference between monofocal plus and EDOF. The monofocal plus is what is high-ons is currently the most popular. So monofocal plus gives the advantage because the cost factor is also there. And that is one of the important factors as far as the patient penetration is concerned in my practice, as well as in others' practice as well. So to start with, I would...
That's the one point. We are not going to take the cost factor. We're just talking about the standards set by the science. That till now we've had monofocal, and then we have lenses which give us different foci, simultaneously different foci.
Yeah.
Now, this is something which is science has. This is a term which has been defined by one particular company which came out with this technology, and thereafter a lot of other companies have come out with the same technology, and it is one group, but the standards per se for this lens have not, the science has not acknowledged it as yet. So this is actually behaving like a monofocal, or we are using it like an extended depth of focus. That's what I want from each one of us, our panelists, that you very clearly said you have replaced your monofocals with monofocal plus. So this is a new monofocal for you.
Yes, absolutely. It's a monofocal. It's got another advantage. What's the advantage of when compared to the regular monofocal lenses which you have been using in the past? Okay, the monofocal lens plus lens gives that extra range of intermediate, and also to a certain extent, because the near point of has shifted from 35 centimeters to 50 centimeters to 60 centimeters now, and patients are able to also read N6 or N8 or whatever it is. And if you have micro monovision, it works wonderfully well because it induces a spherical aberration in the center. It increases the depth of focus, and that is amazing. There are no zones, no photic phenomenon. That is the advantage of this monofocal plus lens, in my opinion. So, yeah.
I think Dr. Narang had a point. Yeah, he has raised his hand. Sir, you're muted, sir.
Muted, Narang.
Hi, everybody.
Yeah.
See, these premium monofocal lenses or advanced monofocal lenses are not at all EDOF lenses. EDOF lenses are extended depth of focus.
Yes.
But these lenses, they are focused on defocusing the image. That means the main aim is to defocus the image by adding some convexity, some curvature on the anterior surface of the lens. And essentially, this is the negative spherical aberration which they use. But there are 2-3 types of platforms available in this premium monofocals, where one like iHands, they have changed the curvature of the anterior surface of the lens, but at the same time, the extended monofocal, these premium monofocal lenses by Bosch and Lomb, they have maintained the asphericity on both the surfaces without inducing the negative spherical aberration, which is there in iHands. So iHands is basically a Technis 1 lens, with increased curvature, while because it has 0.27 micron of negative spherical aberration, but Lux Good lens that I've used few of them, they have both surfaces aspheric, but there is no spherical aberration. That means they say that if spherical aberration is not there, patient is more perceptive, is happier with the defocus rather than with the negative spherical aberration, which is available in Technis platform. I have used few Bosch and Lomb lenses, these premium monofocal lenses, advanced monofocal lenses in both eyes. And surprisingly, they don't even need glasses for reading when both eyes are operated. Even M5, they're able to read. So I was surprised because I've been using eye-enhanced lenses not as a total replacement for monofocal lenses, because there is still some, as Mohan said, he's replaced his total monofocal practice to enhance monofocals. But no, when there is a retinal pathology, geographical atrophy, macular degenerations, where we need sharp focus at macular or paramacular region, still monofocals, premium monofocals have their role. The classic monofocal like techniques, they have their role in these cases. So in my practice, these advanced monofocals have not replaced monofocals totally.
No, I don't understand. If there's a retinal pathology, you can use eye-enhanced lenses. I've used eye-enhanced lenses in patients who got advanced glaucoma, macular degeneration. It doesn't matter because there's only one single point of focus. There are no zones in this lens. Single point of focus.
No. Advanced monofocal, the single point of the basis of advanced monofocal is to slightly defocus the image.
No, it doesn't split the light.
No,
It doesn't split the light. No splitting of
sir,
light.
it's not, sir, MR, sir, there is a basic rule or basic law that we all have understood. There is a give and there is a take here. The multifocality or whatever depth of focus always asks for some contrast in sensitivity loss. This is how it has always, this is how it has worked. But the publications, you're right, the publications around this particular technology are saying there is no loss. The discussion right now, Narang sir is saying that there is the technology is working in the way by that creating the defocus. So the science per se says that it's creating a defocus, but the results published are saying that the contrast sensitivity with these lenses is better or equal, better also. A couple of papers have said it's better than the techniques.
Yes,
So
yes.
that is where the catch is, that what is it there? Maybe Ruth, you can explain. You're into the,
Yes.
your
Well-
PhD in such things.
So in terms of physics, right? The eye hands, for example, the monofocal plus, what it has is it has an adjustment for spherical aberrations.
Yes.
And whether it's centrally on the lens or peripherally doesn't make any big difference. What it does is it actually lowers the maximal visual acuity that you could achieve with the lens by flattening the curve around the zero, and it enhances the visual acuity by a quarter of a diopter, no more than that. And in terms of enhanced reading with those lenses, a quarter of a diopter doesn't give anything to your patient. So the moment you do monovision, that's where the reading vision comes from, not from the eye-enhanced lenses. Now, personally, I think that those lenses were more or less invented to make us doctors have better dependable outcomes, because what we do all the time is our biometries are not always the best. Our calculations are sometimes off. We can't predict higher than 91% between plus and minus 1/2. That's for the best of us, right? The median cataract surgeon achieves 70% of between plus and minus 1/2 diopter post-op. So if we have a lens that's enhanced, allowing this quarter of a diopter of, I call it spiel, you can play with it a bit. It allows you for a better on-target outcome because the lens has this flattened curve around plano. And it's completely different from EDOF lenses, because EDOF lenses, most of them do split the light. Even the Vivity does. It has just one ring instead of a set of rings. All the diffractive EDOF lenses, which is the Lara and I think it's called Symphony by Technis. So these are basically bifocal diffractive lenses, which have the near focus for the intermediate distance and not for near. That's the whole difference there is to it. They don't have less side effects than other diffractive lenses. It's just how they were designed for the near focus to be, whether it's really near or intermediate. And the Vivity in that sense, officially it doesn't split the light. It allows for continuous vision from plano to +1.5 to 60 centimeters. And if you do a mini monovision with those, most patients will be very happy with their far and their near vision. I saw one of the questions asking what's micro monovision. So it's a very good question, because we see in the literature calling it mini monovision, micro monovision. I've even seen a paper in which people were calling it nano monovision. And this is basically our problem with all of those new technologies. There's been an editorial of how to define EDOF lenses in the JCRS, and I would recommend reading that one. There is an ophthalmic technology assessment of the ophthalmology that gives us 7 points plus 4 particular more ones for the definition of an EDOF lens. So this means that the more complex or the technology is, or the more warbled the marketing is, the worse we are off, because we have to decide, are we going with our science or are we going with the marketing, or aren't we aware that someone is marketing us, right? So, yeah, well, I think I've said enough.
Yeah, Master, you want to add something?
Yeah, I mean, the concept of playing around with asphericity started off with refractive surgery, where we were initially trying to have a more curved cornea for presbyopia. That did not work out because of the quality of vision issues. So the principle was kind of applied here. Now the issue is, yes, to a large extent, in my practice, probably I've shifted to the advanced monovision lenses as such, because I don't see negatives in using them primarily in most of the patients, with maybe about a 0.5 to 1 diopter of near vision that they get, because most of my patients, I've seen them somewhere around plus 1.5 to 2, whereas most of the normal lenses would be somewhere around plus 2.5 to 3. So somewhere between a 0.5 to 1. But the problem is, we have, when we talk about playing with asphericity, we absolutely have no idea of what the asphericity of the cornea is, because ultimately it's going to compromise. I mean, it's going to play a role with the asphericity of your cornea to begin with. So if your cornea has been treated with laser refractive correction, the asphericity is totally different. The outcomes, at least in my hands, what I've seen in a post-LASIK patient, the near vision really doesn't improve as much. So whether we need to start looking at the asphericity of the cornea to begin with, that will be one. Second, we are talking about 0.27, 0.3, 0.4, whereas the lenses that we have are in a range of 0.5s. So even if, I mean, it depends on where your plano was. Was your plano at 19 diopters with a 0.01 error, or was your plano at 19 diopters with a 0.3 error, which is again going to affect the outcome in terms of reading that the patient is able to see. So over a period of time, maybe we might probably be shifting more towards a 0.5 diopters lenses once the company goes to it, or we have to make our understanding of which patients would benefit more by playing around with the asphericity. Again, different companies, iHands uses a negative aspheric platform, Rayner uses a positive aspheric platform, and Bausch & Lomb uses on their aspheric neutral thing, they are putting some value to kind of help them see a little bit better. The most important reason why the lenses have got accepted is primarily because of the cost. Because you don't really have to speak too much to the patient. You can give them that little bit extra without them having to spend money and your chair time. Unlike the other premium lenses, where you also have to spend your chair time and the patient also has to shell an extra amount for the difference that is there. But at the same time, the patients have to be aware that with a multifocal or a trifocal, you will have issues with glare, and that give and take, the patient has to be very clear.
I think Ruth, you had a point.
Yeah, so I agree with you that asphericity ideas came from corneal laser surgery. I do think that opening the discussion for the use of these premium lenses for post-laser surgery opens a complete different box of what we're talking about. So I think we should restrict ourselves basically to pristine eyes undergoing cataract surgery. And if we all remember, we used to have spherical lenses in the beginning of the PMMA lenses. I think it's about 30 years ago. And some of our patients could read quite well, especially in the hyperopic eyes in which we were implanting those lenses, because they were basically their basic curve was more spherical. So I think this is an idea that was taken from there. But then if you would measure those people, they would have a bigger range of vision, but a lower visual acuity. And this is the trade-off. This is the no free lunch thing. If you have a bigger depth of vision, you will have less maximal visual acuity with all the lenses that treat the surface by means of adjustments of spherical aberrations. This does not go for lenses with diffractive multifocality. This you can read actually in the papers of Leo with pyramidal aberrometry. He has shown there that diffractive lenses actually give excellent retinal images on the foci they were designed for. So this is really only for the enhanced lenses. And I still remain with my point, and it's like my valued colleague here said, less chair time, because there's really nothing to explain to the patient. It's in favor of the doctor, basically, the enhanced lenses. And sometimes, the patient gets a little bit more of depth of focus, but it allows you to have easier outcomes.
Can I add something?
Yes, sir.
And actually, Madam has also rightly said, Bhaskar has also rightly said. So when we talk to the patients about the different types of lenses, okay, the cost, of course, you said cost should not be. The cost is a very major factor. Because with the cost, what happens is the expectations of the patient also go high. So it's directly proportional. So the patient is going to pay about 1.5 lakhs, 2 lakhs for a surgery. Okay, his expectations is also going to go high. So that is
cost of what? What are we selling? What cost of what here?
No, the cost of the lenses. I'm talking about the lenses.
No, cost of lens thing. The thing is that we are selling something in the technology. Here, this is not a multifocality. We are like...
I'm just coming to the point, Shika.
Yeah, so it is the monofocal lens only. So why the cost issue should come in that?
No. I'm talking about that. I'm just coming to that point. Because when we discuss the chat time, as Madam was telling rightly, the chat time, when you talk to the patient, when you tell them, it's so easy to convince them from a regular monofocal to a monofocal plus, because it's only about 15-20% more than the regular monofocal cost. Okay, so when you try to coax them for a trifocal, a panoptics, or a synergy, your cost is going to be 2.5 times more. And if it's going to be a VVT, extended depth of focus lens, again 2.5 times more. With the cost, the expectations also go high. So that's the reason why the patient satisfaction is not very good. With the high-ans lens of the, I will not mention high-ans, monofocal plus lens. Okay, because monofocal plus lens, why the patient satisfaction is very important. One is because they are paying less and they're getting more. Okay, they're paying less and getting a little more than a monofocal lens. So that is, I think, why it has penetrated the market. And we are also able to see that in clinical practice as well. Because the patient's range is good. We have done a contrast sensitivity study, and we find it's even as good as any of the monofocal lenses. Absolutely.
So you've compared it with Technis?
Technis. I've compared it with the Technis lens. I compared this with the Clarion lens. So all these
the contrast sensitivity is because publications are also saying the contrast sensitivity.
Very good. It's very good. Fantastic. The modulation transfer function is really fantastic. We're doing it on a regular basis. Patients are very happy with the monofocal plus lens. So
At this point, sir, I would like to know what is the final refraction that is that the patient achieves the ad.
no, what I do is for the first eye I aim for plano, emetropia. The second eye I titrate the second eye. After a few days or 1 week, I do the second eye. When I do the second eye, I aim for about 0.5. I land them on 0.5. Sometimes if you aim for 0.5, you can land them on minus 0.75. But doesn't matter. The micro monovision gives them fantastic vision. And I tell the patient you will require a reader if you're going to have 35, 40 centimeters. Many patients who are all active in this, yes.
No,
Yes.
my question here is I'm not trying to find out how to make the patient happy. I'm not trying to find that out. I know here two things are being used, that 0.5 with micro monovision and a little bit of asphericity, that 0.5 diopters we have achieved. And
Yes.
patient is getting some more depth. What I'm trying to find out is that the papers, the science says that it achieves the same amount of near and distance vision, best corrected vision, as monofocal. And only a little bit of intermediate is added. So if we go by that, they are saying that the patient will still require a full ad, whatever you give for a monofocal, that will be required. So do you agree
No,
on that?
I will not
Forget
agree.
micro monovision.
All my high-ans patients, if they want to read at about 40 centimeters, 35, 40, I give them only 1.75 ad. They're very happy with 1.7. Wherever monofocal lenses, conventional monofocal lens, I have to give 2.5 or 2.75. Here about so many patients, they don't require glasses at all, because many of them, as I told you, they are reading at 50, 60 centimeters. These are all young patients, relatively, they're very active in life. And they are all using the iPad and tab. And the tab and iPad is not 40 centimeters anymore. It's about 50, 60 centimeters. And high-ans work wonderfully well. And especially if you do the micro monovision, it works even better.
So you're giving 1.75. You think that the ad can be reduced?
Absolutely.
And ad has been reduced.
Absolutely. Anything less than 2 will work wonderfully well. Even 1 plus 1.5 also are given for many patients.
But the technology around the lens says that it is whatever benefit for intermediate vision is coming, it is irrespective of the refraction. It is irrespective of the refraction. It is, I mean, like the refraction remains the same around it. You still, they don't say that you have to give a lesser ad. The patient will require. And is there any different way of doing the final glass checkup for these patients?
I don't understand your question. Different way means?
No, yeah. So now there is many of the patients might accept a little lesser ad initially, and actually this is Dr. I'm not able to pronounce, Jared Offert from
Jeffrey Offert.
Yeah.
Germany.
So this paper, he has very clearly written that this technology is only the whatever intermediate vision is coming from the surface. It's irrespective of the refraction. And these patients should be refracted by fogging. How we do in younger patients who have the capacity to, accommodate. We fog them with plus lenses and try to give them a lesser minus. So he said it's highly recommended to use that technology, that way of refraction to prescribe the glasses. So I was wondering how many of us are doing that?
Yeah, I'm not doing that, but Sunil are doing it.
Yeah.
Yeah. See, I'm not doing this, and I do not agree with this. In my regular thing, I always aim for plano both eyes, and we have never given more than 1.75 addition.
Yes.
While in routine techniques, I used to give about 2.5, and we have never done fogging for this refraction technique. So there is a definite advantage for less ad. We give less ad for reading, and bilateral. If patient is plano, there is a definite advantage in intermediate vision. without glasses. Patient can work on screen and laptop, like we are keeping a tab at the distance. He can easily work. This is my personal experience, not going according to the papers, and they don't lose any contrast sensitivity in these cases. But I will never use advanced monofocal for any retinal pathology around macula or on macula or any corneal opacity. That's my take.
Sir, so you've not had patients coming back to you that now this 1.75 is not working. Probably 1.75 is good. 1.75 is probably a little more, but if you check in your clinics, patient can, may require 1.25 and 1.5 also.
Yes, 1.25 also patients.
So when you set up 1.75 is a good new insight probably, but if you set it at 1.25 or if you leave it with the patient, then they agree for 1.25 and 1. So there is no standard, and then they come back with their progressives, And so you think that aiming for plano and giving 1.75 in both the eyes, they're happy for good?
No, we start. I had clear instructions to my optometrist that they have to start rather in the reverse. Instead of fogging, they have to start with 1.25. And most of the people, either they accept 1.25, 1.5 and max 1.75. And I have used iHands since I think 2020 or 21. I was just going through the statistics while the previous talk was going on. It's around 2000 now. And I have not seen, maybe they have not come to me, they've come to my associates, but I have not seen.
They have not come to you because it's a definite thing that is happening, that patients who are, I had operated on a dentist as soon as the iHands was introduced. It was, I don't know, 2000, I don't know, 2019 or something, it was introduced.
4 years back, yes.
2 years back. This young dentist,
4 years.
she got operated upon and she was very happy. I gave her 1.25. She comes back to she barges into my OPD and she says, now I'm not able to focus well. Gave her move from, first 1, then 1.5, then 2. She was so unhappy. She said, this is not the way the prescription keeps changing, and you have to tell right in the beginning. She told me you have to get back to the company and tell and stuff like that. Then I was like, maybe she was a diabetic, and there was some fluid at the macula that can cause, I tried to, make myself understand the phenomena. But then I have noticed that going with the lesser ad for these patients, they tend to become unhappy after, maybe 2-3 months. They'll say, I need my own uncle. He's had both the eye surgeries, and I've done both the eyes, and he's gone back to hometown, and he's very happy. He's spectacle free. He was a high myope. He's spectacle free. But what he's saying is, Shika, I need a little more light probably to read, and it is, I can see better without, with that ad, better in bright light. So there is something about the contrast and giving. So there is no harm in giving a proper ad. And probably in the clinic, patient is, agreeing for 1.25. It's a definite phenomenon. You might be having a few unhappy patients who,
Shika, I would beg to differ with you, because if you are going to operate on a high myope, I would put a trifocal lens for these patients. Because these people are all used to good near vision at a very close distance, 35-40 centimeters. And iHands will not work at that level. Please understand. Okay, trifocal lenses is probably the way to go. So myopia patients, high myopia patients, if you're going to put iHands lens, definitely the patients will have, because they are all used to good near vision.
I haven't promised multifocality.
No,
He's still progressive.
Absolutely.
I haven't promised multifocality.
We have done a study now, and we have found out that 30 to 35% of my iHands patients don't use any glasses at all. 30 to 35%. They don't use any glasses at all. They're able to manage because their near vision is not 35 centimeters, as I told you. They are all reading the tab and all the Hindu paper Times of India. They read on the iPad, not anymore on the newspaper. So they are reading 50 centimeters. They were quite happy, and they're working on the laptop, which are all the intermediate distance and high-ans lenses. So I give the remaining patients, I give them 1.5, 1.75. They're all very stable. And we have got probably one of the longest follow-ups. I was one of the first ones to use the high-ans lens in the entire country when we started in 2018 or 19. Yeah. And we have got a huge follow-up. Sunil has also got a huge follow-up. More than 1,000, 1,500, 2,000 cases we have. Yeah.
Ruth, you were saying something?
Yeah, I want to say two things. I agree with Dr. Rajan that most of our patients currently are screenagers. So it's very easy to enlarge the typesetting on your electronic devices. And then, of course, a reading glasses of 125, 175 will be more than enough. They will not be able to read their bottles of medications. They will not be able to read in the supermarket or anywhere else.
That's
Now,
what exactly.
if you do a small Google search for freedom from reading glasses for eye hands, it delivers you 0 results, only marketing. Now there is, for example, a paper from clinical ophthalmology, and this went, and I'm going to try and show it here. This went and showed the difference between Clarion and eye hands. They're the same. There is no enhancement of the intermediate. And I think this is really a myth we need to dispel. It gives a little bit of more ease around the plano. It does not give anything in the intermediate vision. And it's also not meant for that. In Europe, for example, the eye hands is priced the same as a monofocal lens. So the lens is really designed to enable us surgeons to have a better plano outcome if we want to, but it's not going to enhance the intermediate. It's physically impossible with these lenses.
Sorry, Ruth. Another question at this time. Would you call Clarion an enhanced monofocal?
No.
No.
The thing with Clarion is that it's the procedure in which the HEMA was baked off in the Alcon offices. So we used to have the Acrisoft materials, which could have quite high glistenings because of incarceration of small air bubbles within the matrix of the polymers. And they would increase with time, and then you get glistenings, and some of the patients would really have problems with this. Now, this depends on the process in which the HEMA material is produced, and there are processes in which you can get cleaner polymer manufacturing, by which you decrease the glistenings in this material. And that's the only difference between the Acrisoft and the Clarion. It's more clear because it was produced in a different way, it was cooled in a different way, and like this it is clearer Clarion, but it doesn't say anything about its refractive surface. It says about the material. The material is higher grade. And that's where the Clarion really, after years, I haven't seen a Clarion lens yet with glistenings. I was a PI one of the PIs in the longitudinal Clarion study. So I've checked these patients on my own, and we've measured and we counted the glistenings, etc. They're not there. So this was a production thing that was improved, but it's not a refractive improvement.
But you did show just now in your mobile that it's comparable to eye hands.
So what this is Micheletti from Canada. This was Micheletti from Canada who did a head-to-head study of the Clarion versus the ions, and he did the defocus curves, and it shows that basically around I'm going to try to find it again. Well, I can't find it this fast, but I just picked it up on my phone.
No, I will. Can I
It
tell?
doesn't show any difference in the defocus curve. So refractively, the IHANS does not do anything on the intermediate. And this is not the only paper that shows this.
Yeah. No, actually, Shika and others, but the Alcon is now marketing Clarion as a monofocal plus lens.
Yes.
They are marketing it.
Not in Europe.
We're doing a study now. We are doing a study and we are trying to compare that. And we found that study is too now infantile stage, but we'll know the results in another few months or maybe 6 months or so. We need a long-term follow-up because we have a long-term follow-up for the IHANS, but we don't have much for the Clarion. So
that brings us to the question, sir. What is the definition of now that it's coming, everybody here, most of us here are agreeing to some advantage of this technology. So what is the definition? When do you call it? And now other companies are also coming. Why not Clarion when the function is same? Why we don't call it a monofocal plus, and why we are calling IHANS and others monofocal plus? So what is the definition, exact definition? Anybody, Narang sir?
Clarion is just like an IQ lens.
It's an IQ
negative spherical aberration.
Yes.
And just like what is the material difference?
Plus definition of monofocal plus.
Monofocal there is an alteration in the spherical aberration or the negative spherical aberration on the surface. Okay, if you see the thing, it's exactly under the microscope. It is exactly like the Technis lens. There's just an alteration in the curvature on the center of the lens, center of the optic. And that is what is giving the increased depth of focus. But Clarion does not have it. It's like an IQ lens, but the material is good, really fantastic. It's very clear. It's very compatible. I don't see even one small pigment in Clarion and postoperative, much better than the IQ. The loading system is probably one of the best. And the Clarion is come in the VVT platform, the Panoptics platform, everything is so good. Really fantastic. Stability.
Foldability is nice. I've already implanted Clarion Panoptics. It's very nice. I agree with you.
Very good, Manu. Yeah, right.
But then again, the adjustment in spherical aberrations on the IHANS, it gives maybe a quarter of a diopter. And I really think it's there to make the lives of cataract surgeons easier. And the plus is maybe the plus that goes into the balance of the marketing.
Monofocal plus definition. Narang sir, what is it? Mr. Bhattacharya, please tell me the definition.
Yeah, actually, there is no clear definition between a monofocal and an enhanced monofocal lens. As of now, at least officially, we have a clear definition for EDOF lenses. The US FDA spells it out that it has to be 20 by 32 for at least 50% of the patients in the trial at a distance of 65 centimeters, 66 centimeters. In that way, we do not have a clear definition between a monofocal lens and enhanced monofocal or a monofocal plus lens. From my experience, and this is a very humble opinion, I could be entirely wrong, even a monofocal lens will give you a depth of focus of around 0.5 diopters. But a monofocal plus or an enhanced monofocal lens might give an additional 0.5 diopter of depth of focus safely. So studies are showing just a few months back with the Menucci's paper, comparing between many different enhanced monofocal lenses, monofocal plus lenses, shows that one line of, added depth of focus from a standard monofocal lens. That's what the studies are showing. But there's no clear definition as of now.
Agree.
That's what is in most of the presentations, most of the companies' brochures, that it gives you one line plus for near vision without the glasses for the intermediate vision. That means one, if it is with the monofocal, if you achieve N10 with the enhanced monofocal, you can achieve N8 without correction. That's the take home point. Otherwise, the diagram Dr. Ruth showed about that, comparing the IHANS and Clarion, this is being shown by Alcon people to everybody just to tell the people that Clarion and IHANS, they are same, but they are not.
Not the same.
I've used both, but IHANS or I should not be naming the IHANS, but these advanced monofocal are definitely better than only Clarion. Clarion is essentially a IQ lens with a different material, of course.
Absolutely.
Fine. Any other points? That was a great discussion. So at the end of it, monofocal plus is a new set of lenses waiting to be acknowledged by these standards set by the world, probably. Any other questions? Thank you so much, everybody.